This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to our Rational Wellness Podcast, please go to Apple Podcasts and give us a ratings and review. That way more people will find out about the Rational Wellness Podcast. Also, there's a video version on YouTube if you look up Weitz Chiro or Rational Wellness. And if you go to my website, you can find show notes and a complete transcript. So our interview today is with Dr. Alan Goldhamer, and we'll be talking about fasting. There's been a lot of discussion in the health and nutrition world recently about the benefits of a complete fast, of intermittent fasting, and other variations, such as the fasting-mimicking diet and even the ketogenic diet. In recent weeks, I have interviewed Dr. Josh Axe and Dr. Christopher Shade about the benefits of the ketogenic diet, and we discussed its anti-aging benefits as well as its potential benefits as a therapeutic diet that may be a benefit for diabetes, hormonal imbalances, for brain health such as Alzheimer's, as well as for weight loss and even cancer. Now we will be speaking to Dr. Alan Goldhamer about fasting for as long as 40 days with supervision, followed by a plant-based diet that may have many of the same benefits, including for hypertension, diabetes, and autoimmune diseases. Dr. Alan Goldhamer is a doctor of chiropractic who founded and runs the True North Health Center, a state-of-the-art facility where you can stay to be monitored while doing a water-only fast for up to 40 days. He's the author of the Health Promoting Cookbook and co-author of The Pleasure Trap, Mastering the Hidden Force That Undermines Health and Happiness. Dr. Goldhamer has supervised the fasts of over 10,000 patients. Under his guidance, the center has become one of the premier training facilities for doctors wishing to gain certification in the supervision of therapeutic fasting. Dr. Goldhamer was a principal investigator in at least 2 published studies, medically supervised water-only fasting in the treatment of hypertension, and medically supervised water-only fasting in the treatment of borderline hypertension. Okay. And he has several other studies currently being conducted. Dr. Goldhamer, thank you for joining me today.
My pleasure.
Can you tell us about your background and how you became involved in treating patients with nutritional interventions, especially using water-only fasting?
Well, I went to Western States Chiropractic College, and after that, attended the Pacific College of Osteopathic Medicine in Australia, where the gentleman I trained with had an osteopathic hospital that specialized in medically supervised fasting. So I got to see a lot of patients that were sick get well by essentially using fasting followed by a whole plant food SOS-free diet. So, that was my initial exposure. When I came back to the United States in 1984, my wife, Dr. Morano, and I opened up the True North Health Center. And we've been doing this ever since. We've had over 20,000 people now go through medically supervised fasting in the last 35 years. And we've had a chance to see just how good a job the body does at healing itself if you get out of the way.
Interesting. So what are some of the benefits that you've seen of doing this water-only fast?
Well, it turns out that a lot of people are sick today as a consequence of dietary excess. So they have obesity and high blood pressure, type 2 diabetes, autoimmune disease, and conditions including things like lymphoma. And when you do fasting, it gives the body a chance to mobilize and eliminate those consequences of dietary excess. So we treat a lot of patients with high blood pressure. In fact, we did a study with Cornell University. We took 174 consecutive patients with high blood pressure. 174 people achieved pressure low enough to eliminate all medication. We have the largest effect sizes that have ever been shown in treating high blood pressure in humans using fasting and a whole plant food diet.
Interesting. What are some of the other conditions?
Well, we treat a lot of type 2 diabetics where insulin resistance allows blood sugar levels to rise, and insulin resistance is reversed with fasting and maintained with diet and exercise. So it's not surprising that, a high percentage of type 2 diabetics are able to achieve normal blood sugar without medication. We also treat a whole host of autoimmune diseases where it's actually the immune system attacking their own tissues. So, for example, in arthritis or rheumatoid arthritis, it's actually the body's immune system that's creating the inflammatory process associated with the pain and deformity. And in part, that may be triggered by processes including gut leakage, where proteins are absorbed to the system, stimulating genetically vulnerable people's immune system to attack itself. With fasting, it's like rebooting the hard drive on a computer that's become corrupted. A lot of stuff clears away. You don't always know exactly the mechanisms, but it works very similar in autoimmune disease. Gut leakage tends to be reduced, and then followed by a low antigenic diet, you can often manage these conditions without the devastating effects of long-term anti-immunological drugs, including steroids, methotrexate, and the rest of it.
When you say gut leakage, you mean what we often call leaky gut or hyperpermeability?
Yeah, the idea that there's a membrane in the intestinal tract that prevents larger molecules from being absorbed into the body unless that membrane becomes damaged. One of the common thought
which is the gastrointestinal mucosa.
Absolutely. So it works very much like a screen works to keep flies out. As long as the holes are small enough, only the stuff it's supposed to get through does. But if through, for example, exposure to free radicals or other source of irritation, inflammation, that membrane becomes damaged, you may see particles being absorbed into the immune system that shouldn't normally be there. And initially, that's not a big problem. The body's immune system reacts. But for reasons still to be determined, in genetically vulnerable people, that immune system can become overwhelmed or confused and begin to react to its own tissues. And it may be this mechanism is maybe the reason we see such improvement in fasting, because you get a chance to reduce that inflammatory response. We know that's happening because acute phase reactive proteins consistently go down during fasting.
Yeah, we usually think it's because of cross-reactivity. So proteins like gluten cross-react to proteins in a body that look similar. So do the patients drink unlimited water, or is there a danger of drinking too much water?
Well, too much water. Well, I guess ultimately too much water would be called drowning, wouldn't it? So no, we do monitor patients' fluid intake. We want a minimum of 40 ounces a day, but not so much that they flush out their electrolytes. So we're monitoring blood and urine testing in order to make sure that people are maintaining a reasonable balance. But most of the detoxification that occurs because the blood is being processed by the kidneys and it's going to show up in the urine. So you need enough of a solute in order to be able to have a place for the intermediary products of metabolism, exogenous toxins that are being mobilized that can be processed and eliminated. Too little is not good. You get dehydrated too much, can be a problem if you flush the system out excessively.
What kind of water do you give them? Is it
we use pure water, which is fractionally steam distilled water, although you could use probably any type of purified water.
So if you do that, that water's depleted in minerals, right?
It is depleted in minerals. It's just pure water, which is what rainwater would be if you didn't have a polluted atmosphere. But the gut's not a two-way gradient in a clinically significant way. So you're not sucking the minerals out of the body through the intestinal mucosa. You're able to maintain balance, including on 40-day water fasts on distilled water only.
Really? So even without any food, aren't some of these people getting electrolyte depleted?
Well, we monitor electrolyte balance on every patient and ensure that potassium, sodium, and the other electrolytes are maintained in normal course. And of course, in appropriately selected patients, they're able to maintain electrolyte balance through up to 40 days.
Do you ever give them electrolyte or other supplements?
Well, we do not supplement during fasting. In fact, you want to use, we use potassium and other nutrients as rate-limiting nutrients. If you supplement just those isolated nutrients, the 20 other downstream less sensitive reactants that you wouldn't be monitoring for could become a limiting factor. That would be very dangerous. So by not supplementing, you actually eliminate the risk of overall imbalance in the system. And that's how we've been able to do this 20,000 times. In fact, we published a fasting safety study that's really scientifically analyzed the safety and efficacy of fasting. And we've shown it, using this protocol, it can be done safely.
Which patients do you find are not eligible for such an approach?
Well, there's a wide variety of people that fasting would be contraindicated, not the least of which would be pregnant and lactating women, people that have had recent um, problems with stroke, heart attack, uh, uh, dysrhythmia, people that are on anticoagulant therapy, drugs that you can't stabilize people off of, people that have neuropsychiatric involvement that might prevent them from providing informed consent. There's a whole host of people that you wouldn't be a good candidate for fasting. That's why every patient we see goes through a careful history exam, lab monitoring, and screening.
Well, what about patients who are on hypertensive meds? You mentioned
Well, there's
hypertension.
really no problem with hypertensive meds because what we do is we get people on a whole plant food diet in the days prior to fasting. You're able to wean those medications. And then as soon as you go on the fast, there's a precipitous drop in blood pressure. So we're able to safely wean people off blood pressure medications with limited challenge. The effect side, the diuretic effects of fasting are so powerful. They're much more powerful than the medications that people are used. And so within short order, people's blood pressures begin normalized. In fact, most people are not even medicated for their hypertension. They're medicated for the diet that's causing the hypertension. And literally the day you change the diet, blood pressures begin to respond. Many of our patients come in 220 over 120, capped out on medications. And yet by the time we're done, they're 100 over 60 and maintaining that level essentially as long as they're willing to do the diet and lifestyle changes. It's much like obesity. If you eat well and you live right, you maintain the result.
So during the fast, you have an MD on staff who's monitoring them, who lowers or takes them off their blood pressure meds?
Every patient in our facility has an attending. We have 6 medical attendings that are full-time employees of the True North Health Center. Right. So every patient has an intake and exit exam with an attending, which is responsible for monitoring their care and managing their medications. Our daily rounds are typically done by doctors of chiropractic or doctors of naturopathy. Each patient is seen twice a day by one of our staff doctors. All of that information is reported to the attending that's responsible for ongoing medical management of their care.
What about patients with cancer? Are they good candidates for this?
Well, it depends on the patient, but we just published a paper recently, which is a follow-up to a paper we published 4 years ago in the British Medical Journal on the treatment of follicular lymphoma with cancer. And this was this case report was a patient with stage 3 follicular lymphoma, been confirmed by excisional biopsy, monitored for 2 years with progression, underwent 21 days of fasting, completely resolved her tumors, 10 days of refeeding, back to the medical school for follow-up. Not only did she eliminate her lymphoma cancer, but now on 3-year follow-up, we were able to demonstrate she remains cancer-free, and we published a follow-up in British Medical Journal to that case report. And those papers, in fact, all the studies I'll be citing are available on our website, healthpromoting.com. People can download any of the papers and look for themselves and see what kind of results we're using with fasting and dietary intervention.
When you're dealing with cancer patients, sometimes weight loss is a problem. How do you avoid them losing too much weight while being on a fast?
Yeah, well, of course, weight loss is a problem in patients that are in cachectic stage of cancer. You know, they may not at that point necessarily be a candidate for water-only fasting. Most of the patients that we're seeing, particularly with lymphoma, these are patients that, you know, weight management isn't generally the limiting factor. So usually, what you'll see a lot of patients that, you know, particularly when they've gone through medical treatment, end up with cachexia and have problems because of devastation, not only from the cancer but from the treatment. Generally, these are pre-treated patients. These are with lymphoma. The medical management has some great limitations and a lot of side effects. It's generally deferred, which makes it a very convenient case for us to treat conservatively because they're really not doing anything for a while, and so it's not considered unethical to intervene from a chiropractic perspective and actually get the person well.
Yeah, and I do know that some oncology centers will have patients fast around the treatment, maybe a day or two prior to their getting a chemo infusion, the day of, and maybe a day or two afterwards.
So Walter Longo was the first person who published 2015 article in Journal Metabolism, resulting some animal studies that he had done. 30 rats with cancer, given enough chemotherapy to kill all the cancer cells, kills all the rats. Take the same rats, same cancer, but now fast rats before and during chemotherapy. All 30 rats survived, dramatic increased survival. So he was the first person that I saw talking about the idea that fasting actually helps protect healthy cells from the ravages of chemotherapy and makes cancer cells more vulnerable to treatment, alternative or conventional. It's interesting to note that many of the biomarkers associated with cancer also turn off whether you do chemotherapy or not, just in response to fasting. So
Like, which
clearly,
biomarkers are those?
there's a whole host of, ranging from acute phase reactive proteins on down. So there's a whole host of markers he talks about in his article in Journal of Metabolism 2015. And his conclusion was that the use of fasting in conjunction with chemotherapy dramatically enhanced cancer-free survival. And so now people are beginning to apply these principles in humans as well. And that would be more short-term intermittent fasting, a little different than the long-term medically supervised fasting that we've been discussing up to this point.
I've really been enjoying this discussion, but I'd like to pause for a minute to tell you about our sponsor for this podcast. I'm proud that this episode of the Rational Wellness Podcast is sponsored by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help our patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative. This is a great resource for education for practitioners. I'm a subscriber to TAP Integrative. There's videos, there's lots of great information constantly being updated and improved upon by Dr. Lee Salschuler, who runs it. One of the things I really enjoy about TAP Integrative is that it includes a service that provides you with full copies of journal articles, and it's included in the yearly annual fee. And if you use the discount code Weitz, W-E-I-T-Z, you'll be able to subscribe for only $99 for the year. And now, back to our discussion. How do you decide what length of fast is appropriate for a patient who comes to see you?
Well, a lot of times you don't know when you start the fast what's going to be ideal until you see how the person responds to fasting. Fasting is therapeutic as well as diagnostic. In the case of blood pressure, though, we want to fast people until their blood pressures are entirely normal off their medication. And so it can range anywhere from 5 to 40 days. Occasionally, people need to fast longer than they have the reserves for. And so we'll have to terminate a fast, rebuild them, and then start over again and do it again. And you continue that process until the condition's resolved.
How do you determine that they've depleted their reserves?
Well, we're monitoring their electrolytes. We're monitoring their clinical picture. They're being examined twice a day. So between blood, urine, and physical examination, there's a number of parameters that we use to determine status and fitness and appropriateness for fasting.
Are these patients allowed to exercise while they're fasting?
We restrict activity during fasting. We do have like some stretching classes and chair yoga and different things that we encourage them to do. But we do have to limit aerobic activity because once you've depleted glycogen stores, the only source of energy for extra muscle or brain use would be breaking down proteins through gluconeogenesis. We want to minimize protein utilization, maximize fat loss, and detoxification. So that requires that fasting be done in a resting state.
I saw a testimonial on your website from a woman who had bulimia who went through your fasting program. I thought that was kind of unusual. I wouldn't, putting somebody on a fasting program who has bulimia tend to encourage anorexia or more bulimia.
Well, let's be clear, anorexia nervosa and bulimia are completely different conditions. We don't use fasting for anorexia nervosa, which is a neurological condition where people have dysmorphia. It's a whole different kind of category of illness. Many bulimics are bulimic as a maladaptive response to their dietary issues. They don't want to be fat, but they are addicted to the pleasure trap, the artificial stimulation of dopamine in the brain that comes from chemicals added to their food like oil, salt, and sugar. So a short period of fasting can reboot that mechanism, increase leptin levels, normalize blood sugar levels, get rid of a lot of the biological triggers that stimulate bulimia. And so it is possible to use fasting in an appropriately selected patients as a means of helping mitigate this aberrant behavior pattern. But typically, the focus in eating disordered patients is teaching them to eat healthfully. And so generally, fasting wouldn't necessarily have to be used to be effective in managing that condition. We do have behavioral cognitive clinical psychologists that do a good job of helping people address the psychological aspects of it. And diet and lifestyle and exercise often help address the physical aspects, but fasting does sometimes have a role in helping. It's just like, for example, in cigarette smoking. If you fast a cigarette smoker, by the second or third day, there's really no cravings for cigarettes anymore. So it's a way of facilitating that transition off of nicotine. Now, some people say, yeah, well, they're so miserable fasting, they don't even think about the cigarettes, but that's not really the case. The fact is that the adaptive processes that occur in normalizing function often happen much quicker in fasting. It's a faster way to get to the end result.
Interesting. So you really see bulimia as completely different than anorexia.
It is completely different.
I think most people tend to put it in the same bucket of.
Mm-hmm. Most people are mistaken, though, if you look at the actual condition. It's a completely different condition.
Okay. So have you had any challenges running a fasting program as a chiropractor?
Well, I think running a fasting program as any type of doctor is going to present problems, particularly in the past. As a chiropractor in 1984, when I went into practice, they hadn't had the Wilk decision at that point. So the Committee on Quackery, or the Committee to Eliminate Chiropractic, was still in full force. So doing anything as a chiropractor that, was considered outside the box. Up till even relatively recently, the California Board of Medical Quality Assurance had suggested that fasting, or recommending fasting to a patient, might constitute such a gross violation of the standard of practice that it rose to the level of criminal negligence. At one point, I was represented by a criminal defense attorney. So, I remember being the first person in my family ever to need the services of a criminal defense attorney. My father was very proud, but I did get a lot of advice from other chiropractors, though, that had served time in prison for practicing chiropractic around in the 50s. And they said, well, just treat the guards and they'll take care of you. So, Fortunately, it never came to that, because they kind of decided, actually, on review. At that time, even Medicare had a provision to reimburse fasting, but it was only if it was necessary for rapid weight loss for urgent surgery. So if the patient fasted and got well, it wouldn't be considered a covered benefit. As far as any hospital in this country to this day will use fasting for certain conditions. Like if you come in with acute pancreatitis, they'll put you on IV fluids and no food and use fasting in order to manage the condition. So, once we really got into the weeds on it, I realized that recommending fasting really wasn't criminal behavior. Now, what's interesting is recently, in large part because of people like Walter Longo and a gentleman we've done some research with, Luigi Fontana at Washington University, we've gone from being criminal quacks to cutting-edge researchers, because now fasting has gained some notoriety and some interest. And so we're doing the exact same things we've always done, but now it's viewed differently. And so we're currently working on a study. We're about halfway through with the Mayo Clinic. We're looking at the primary prevention of stroke through the use of fasting and dietary change. We've completed a study with Washington University looking at biomarker changes in fasting. They're counting the number of mutations in B lymphocytes and looking at autophagy and the gut microbiome, the 1,000 strains of bacteria that live in the gut and how they're influenced by fasting. We have completed a study which is called a taste neuroadaptation study that looks at the changes in the perception to food before and after fasting. And we're working right now on a project that we hope to do with Kaiser Permanente, where we look at adding to standard Kaiser care this type of a model of intense education and nutritional support at the management of high blood pressure, and compare, what happens when you educate patients and get them eating well compared to standard medical management. So lots of interesting things going on. We've published a number of papers. In addition to our papers on hypertension, we published a fasting safety study, these case reports in the British Medical Journal on the treatment of follicular lymphoma. We have one paper we published on the chiropractic management of subacute appendicitis using fasting and dietary change rather than surgery. We've got additional papers on a number of subjects, all of which can be found on our website. In fact, our foundation, the True North Health Foundation, is a 501c3 nonprofit research foundation. It has a website, fasting.org, and everything about fasting that people might want to know, they can find just by going to fasting.org.
So you mentioned Dr. Longo, and he's recommending a super low calorie program that you do for 5 days on a monthly basis or something like that. And he claims to get the same benefits that you do with fasting.
Well, he doesn't claim that you get the same benefits that you do with fasting. What he claims is that even just doing Prolon 5 days a month, which is a 600 calorie, higher fat, low carbohydrate substance, even that is enough to induce some of these changes that are associated with fasting. And this is something that patients can do on their own. They purchase this product, they take the product, and he's got some evidence to suggest that that may be helpful. So even not eating greasy, fatty, slimy, processed crap 5 days a month is enough to start inducing biological changes in people. But I don't think anybody's going to compare a 5-day intermittent fasting mimicking diet with long-term water-only fasting. Now, what's interesting is the Longo group has approached us, and we are going to be trying to do some collaborative comparative research looking at long-term fasting, which really needs to be done in a medically supervised setting like the True North Health Center, and the intermittent fasting with products like Prolon, and we'll compare and contrast and see how they can be used independently or possibly together. One of the suggestions they made is we may want to use a product like Prolon as an ongoing source of, to improve long-term compliance, et cetera.
I understand that you believe in a high starch, low fat, low sodium, plant-based dietary approach.
Well, a whole plant food diet is about 10 to 12% of calories from protein, about 15 to 18% of calories from fat, with the balance coming from whole plant carbohydrates.
So that's a high carb diet, a low fat, high carb diet, essentially.
Well, I think many low-fat diets are advocating less than 10% of calories from fat. So this wouldn't technically be considered a low-fat diet because there's still nuts, avocado, other plant-rich sources of whole fat in the diet. So it's 15 to 18% of calories of fat is more of an intermediate fat diet compared to the lower fat, no sources of plant fats in the diet.
Well, one of the benefits of fasting is to lower blood sugar levels, which is why you mentioned that's beneficial for type 2 diabetes. And many advocates of a high-fat, super low-carb ketogenic diet claim very similar benefits to fasting, including improving insulin resistance, inhibiting mTOR, stimulating AMPK, stimulating autophagy as part of an anti-aging approach. But
okay, so there's no question that a high-fat, high-protein, and/or high-protein diet, low in carbohydrates, short-term will result, obviously, in lowered glycemic response. But it's not a healthful, sustainable, long-term diet, in my opinion. So when you put people on high-fat, high-protein diets, particularly over the long run, there's all kinds of clinical problems that occur. And even many of the people that advocate these diets advocate them more short-term as a fasting mimicking type of effect, because they don't have the ability to say actually put a person on an actual fast, or that it's not water fasting isn't something people are going to be doing on their own at home. So they'll implement these diets, and over the short run, they'll demonstrate some good results. Just getting all the refined carbohydrates out of the diet does tremendous benefit for everybody. But you need to differentiate an 80% calorie of refined carbohydrates from sugars and processed foods from a whole plant starch-based diet, which is the way the human beings are just what they're designed to eat. And you can sustain this whole food plant-based diet indefinitely. And we've published the data to show what happens when you treat, for example, high blood pressure with this approach. You normalize blood pressure and you sustain it indefinitely. We've demonstrated the effects of not only normalizing blood sugar levels, but the fact that you can sustain those levels as long as people are willing to comply with a health-promoting diet. And I've never seen anybody produce the results that we've produced in treating autoimmune disease long-term. So I think we have to be careful about therapeutic interventive diets that are high in fat and protein versus a sustainable long-term health-promoting diet consistent with our biology.
So what types of starches do you recommend as part of your program?
Whole plant foods. So things like you have a host of tuberous vegetables like Hubbard squash, butternut squash, kabocha, sweet potatoes. For patients that are not lectin sensitive, they may be able to eat non-glutinous grains like rice, quinoa, millet, etc. And there are also, again, for people that are able to tolerate beans, there's lentils, peas, and beans. Some patients don't do well with those products, and so we'll use starchy vegetable materials instead, mostly your tuberous squashes and sweet potatoes.
Sweet potatoes and squashes. And which patients are sensitive to lectins?
Well,
or how do you determine that?
Yeah, some of the patients that you see having autoimmune-related symptomology, particularly people with gastrointestinal inflammation, ulcerative colitis, Crohn's, these conditions, some of the patients that have other manifestations of autoimmune response find they'll do better, at least initially, getting rid of some of the more complex products like particularly glutinous grains, but even some standard grains and beans. Again, frankly, for most of our patients, once we get them fasted, get rid of the gut leakage, and rotate food back in other words, some patients can have foods once a week, but they may not want to eat them every single day because they have some sensitivity issues. But they can get on a whole plant food rotational diet, maintain good clinical outcomes, and not have to be as restrictive as maybe other people that have not had the benefit of fasting. If you're going to do this change without fasting, it can take weeks or months to get the changes that you see in days or weeks with fasting.
Do you recommend whole wheat bread?
We don't use any glutinous grains with any of our products. All of our cookbooks are whole plant foods, SOS free, so salt, oil, and sugar free, and also gluten free. So we don't use wheat, rye, or barley as grains for any of our patients, and particularly for the third of the patients that are particularly sensitive to that.
Do you advocate eating nuts and seeds and other sources of fat like avocado, olives, coconut?
For patients that are able to tolerate those, and most people are, we'll use up to a half an avocado or up to an ounce of raw nuts or seeds a day. But we do limit them in the sense that we want to keep the fat around 15 to 18% of calories from fat. So if you use unlimited amounts of nuts and seeds and avocado, they're very rich. Percentage of calories of fat goes higher than we think is probably long-term ideal and sustainable.
What's wrong with having a lot of fat?
Well, we believe that the patients that maintain the best, both weight balance as well as cardiovascular and autoimmune health, have fat in the 15 to 18% of calories from fat range. You may be able to demonstrate a higher percentage of fat intake for some individuals and maintain good clinical results, but our general observation has been that when we get the percentage of calories from fat higher, it's harder to maintain optimum weight control, it's harder to maintain optimum immunological function. But obviously there's a range in people and a range in sensitivity, and these are the basic dietary standards that we've implemented at the clinic, and they seem to work very well.
So why do you recommend a low salt diet? Are you familiar with Dr. Nicolantonio's book, The Salt Fix, where he lays out some pretty compelling evidence that a low salt diet is actually harmful, that a low salt diet increases LDL cholesterol, activates our renin-angiotensin system, which actually makes high blood pressure worse.
Yeah, of course, that's not at all what our experience has been. And again, I think I'll point to our data. We not only achieved the highest effect sizes ever shown in normalizing blood pressure, we're able to show you can sustain it. And we do that on a diet that's between a half a milligram and a milligram of sodium per calorie, which is consistent with what any whole natural food diet would be without adding a chemical in the form of sodium chloride to the food. You don't need to add salt to your food anymore. You need to add sugar to your food, or you need to add oil to your food. The fact is, a whole food diet has around a gram of sodium naturally inherent in the food, which is going to meet everybody except your rare person has hypoparathyroidism or some problem producing mineralocorticoids or absorbing sodium. And so the idea of salt, though, you want to be real clear about it. Salt is an essential nutrient without which you die, but you don't need to add any added fractionated salt. You get the sodium in your food. That's one of the reasons you are very sensitive to sodium intake, is you're able to pick that up. It's one of the essential nutrients you need. The problem is that salt, if you think about it, was used as a preservative. So in those times before refrigeration, it was a valuable commodity salt the food allowed to be antibacterial. When you add a high salt diet, think about the 5 pounds of bacteria that live in your intestinal tract. It may not be the very best thing to be doing is putting a concentrated preservative agent into the intestinal tract when you're trying to maintain normal balance of 1,000 strains of bacteria. Salt also has a powerful stimulation of passive overeating. And so one of the reasons why excess salt makes people fat is because of the stimulatory effect it has to the apostatic mechanisms. For example, if you give an animal or a human, let it eat its satiety of a certain thing, say you're eating rice or something, whatever, you'll eat a certain amount and eventually you feel satiated or full. If you take that same animal or that same person, everything else being equal the next day, give it the same exposure but salt it up, they'll eat significantly more before they reach satiety. And some people will say, well, that's because it tastes better. Yeah, well, that's what tasting better means, is stimulating dopamine production in the brain. And it can lead to stimulating the cram circuits and overeating. When you do that consistently, it helps make people fat. Salt causes people to retain fluids, particularly the third of the population that's highly salt sensitive. And if you look at hypertensive patients, it's the majority of them. And so what happens is until you reduce that sodium intake, it's very difficult to achieve and maintain normal blood pressure. And so the idea that, not adding, chemicalized salt into the diet is some kind of limiting factor, I find inaccurate and inconsistent with our experience.
Now, isn't salt a way that we supplement our population with iodine to prevent goiter?
Yeah, it is. We've decided to add one chemical to another chemical, and so that's a common way of getting it. And for people that live, for example, in the Midwest, where the soils aren't naturally high in iodine because they've never been covered by the oceans, that could be a serious problem if you didn't supplement iodine. Or if you didn't use foods that are naturally high in iodine, like, for example, sea vegetable materials. If you include a little bit of kelp or a little bit of dulse and things, you're going to get some additional iodine that way. If you get vegetables grown on soil that is iodized, then vegetables do carry significant quantities of iodine. But it is a theoretical limiting nutrient because plants don't have to have iodine in order to survive. So like vitamin B12, which needs to be supplemented on a whole plant food diet, iodine and vitamin D are other nutrients that have to be evaluated to make sure that you're getting enough sun exposure to form your D, and that you're getting plants that have either iodine or take an iodine supplement or sea vegetables in order to ensure that iodine is adequate in the diet. You don't need to add salt, though, as the only source of getting iodine. I think it's a poor choice.
So do you advocate everybody take a multivitamin that contains iodine, B12?
I do not recommend a multivitamin because there's many nutrients in multiples that are frankly harmful, and not the least of which would be iron supplementation in males, for example. Vitamin A is
most of us are not putting men on multivitamins with iron in it.
Yeah. So the point is, I wouldn't recommend taking any nutrient other than the nutrients that you think you have clear clinical justification for recommending for that given individual patient. So the only nutrient we recommend routinely in vegan patients is vitamin B12. And then beyond that, it would depend on, patients, their diet. I think the best source of most nutrients is diet. And for people that get all of their calories from whole natural foods, nutritional concentration of most common nutrients can be good. If it's not, then you can supplement nutrients that are necessary. But the wholesale, just to be sure, I think has as many potential problems as it has benefits.
Now, don't we see in some of the healthiest populations dietary patterns that are much higher in sodium, like the Japanese diet, the Korean diet, and the Mediterranean diet? These all contain moderate to higher amounts of salt than you're advocating.
Yeah, you do see differences in population and different disease patterns. What I'm really talking about here is what we found is the most effective way of both achieving and then maintaining health long term. And a lower sodium intake for the thousands of patients that we're monitoring now appears to be a very helpful way. And when you really think about it, right now salt is more popular to think as a critical. They're advocating adding to the food. You could make the same kind of argument for sugar. You can make the same kind of arguments for oil. People like to hear good news about their bad habits, and it's difficult to adapt to a low sodium diet. It takes people about a month to adapt to a low sodium diet without fasting. It happens a little bit quicker with fasting. Once people make the adaptation, though, then they like their food without adding this artificial stimulatory chemical to the product, and they function and do quite well.
I think one more thing on the sodium is I think there's been quite a number of studies showing that lowering sodium intake had no appreciable benefit for hypertension.
Yeah, lowering sodium intake from very high to only moderately high doesn't seem to have much of a threshold. They'll say the same thing with eggs. If you're already on a high-fat diet and you add a couple more eggs, it doesn't make much difference. You have to look at those studies with a little bit, kind of a grain of kelp. Because what they've never done is actually looked at what happens when people actually go on a health-promoting diet. They're talking about, we'll drop the sodium from 3,000 to 2,400 milligrams. We don't see appreciable changes. Look at our outcome data. 174 out of 174 people with hypertension achieve normal blood pressure, and the people that sustain the diet sustain the results. If you can give me better data, then I'll look at, modifying the program. But right now, that's the largest effect size that I've seen, and it's certainly consistent with the results that we're seeing at the Trimmer Health Center. So
you think eggs contribute to heart disease?
Well, I don't know. We don't use any kind of animal products, meat, fish, fowl, eggs, or dairy products in any of our foods. So I'm not an expert on, what does or doesn't happen with the use of animal products. Not something that we use in the diet at all.
And why don't you use any animal products?
Because I believe that the negative effects, the biological concentration concerns with animal products, the excess fat and protein and the effect that has on heart disease and cancer, not to mention the moral, ethical, spiritual, and environmental impacts of animal-based diets, make it better to adopt a whole plant food SOS-free diet than it does to dabble in the biologically concentrated, dead, decaying flesh, coagulated cow pus, and chicken ovums.
How do you get enough omega-3 fats?
Well, there are some foods that are very rich, some plant foods, very rich in linoleic acid. For example,
Yeah, but
walnuts,
very
flax
small
seeds.
percentage of that gets converted into EPA and DHA.
Well, actually, I don't think I completely agree. There is a difference in some people. Some people do have conversion issues where their percentage are going to be smaller than others. But in our experience, most patients that are getting a 15 to 18% of calorie from a whole plant food diet are able to maintain acceptable levels of DHA. If you were concerned about it, you can use a vegan DHA supplement from Artec. They have lichen-based DHA supplements or DHA EPA supplements. So if you're concerned about it, that would certainly be a way of increasing DHA without necessarily having to use, higher fat intake foods. But in most of our patients, they're able to maintain normal essential fatty acids without having to resort to supplementation. But it's certainly an option if a person has a conversion issue.
Well, I mean, my understanding is even at best, you're looking at 12 to 15% in somebody who's really efficient. So that means, depending upon what you think is an optimal level for...
Well, that's the debate, isn't it? There's no real clear-cut scientific literature about what's optimum levels of circulating DHA. So even when you're doing testing, it's not absolutely clear yet. What's optimum, what's suboptimal. There's legitimate debate amongst people. But my point is, the answer could be supplementing with preformed DHA from algae. I mean, that's where fish and other animals make their DHA. You can go to the source and use the supplementation of DHA EPA that's perfectly acceptable at any dose that you decide clinically that's necessary. Sure. See, a lot of people are using these pharmacologically. They're trying to increase DHA in order to suppress inflammation associated with autoimmune disease. We're actually going a step further, which is getting rid of the source of the autoimmune disease. And then once the pain's gone, people are less concerned about pharmacologically managing it with a less toxic substance. So,
well, many of us are trying to get to the root cause of autoimmune disease. Some people see inflammation as one of the causes. Other people, in some people, it's probably a series of different triggers, including food sensitivities, and then So,
but when we really get down to the basics, the things that we have the most control over are diet, sleep, and exercise. And the point I'm making is if we control diet, sleep, and exercise, oftentimes we get significant improvement clinically. So the need to for example, get rid of the pain because we're taking high dose of DHA trying to suppress the inflammation, that goes away. And so their CRPs normalized, their acute phase reactive proteins normalized, whether we're dosing it or not. If they don't, I got no problem. Do whatever you have to do clinically to get clinical control. But a lot of times people have never gone the extra step to get people on a whole plant food SOS-free diet, get them sleeping adequately, get them exercising appropriately. And that's one of the advantages in inpatient facilities. We have highly motivated people that will do all these things. And when you do that, you start seeing all the pills, potions, powders, and treatments are really the feathers on our rattle. They're not the core. The core is diet, sleep, and exercise. And when you fully implement diet, sleep, and exercise, you get the results that we see at the True North Health Center. I'm not saying it's practical. If you're in an outpatient practice working with people that are having trouble getting to even quit smoking, that our approach is going to be necessarily useful. But for the people that are really serious about getting healthy and they're willing to do anything, even eat well or exercise or go to bed on time, see a chiropractor, do a fast, really radical things, this is the results that are possible. And so, again, I don't pretend that you could extrapolate this to the whole population. That's not what I'm suggesting. But in the appropriate people, this is a really cool approach. And it doesn't prevent you from saying, okay, we've done all that, and now we're still having some stuff. Let's look at our options, whether they're medical options, whether they're nutritional medicine, functional medicine. That's no problem. I have no difficulty doing whatever you have to do clinically to move a person in the right direction. But let's not pretend that the answer is a deficiency of pills, potions, powders, that's the fundamental problem. It may be the necessary clinical application, but it's not the fundamental deficit. That's going to come back down to first level therapeutic order intervention is the naturopath.
I think most of us, at least most of the people in the functional medicine world, integrative medical world, and I know and speak to, all agree that the fundamentals are sleep, exercise, nutrition, stress, reduction, etc. And using things like nutritional supplements are only to be used once those pillars are in place. The question is, what is the best dietary approach? What is the best exercise approach? And that's
right. And I think those are all perfectly legitimate debates. But I also think that it's up to those of us that are advocating radical interventions, and what we do is considered radical, to prove it. And that's why we have a federally chartered IRB, and we've got a nonprofit research organization. We're trying to publish the results of what we're seeing. So if it can be done better, that's great. We'd love to know how to do it better. We're open to that. But at this point, for example, when we treat something like high blood pressure, I haven't seen anybody that's getting better, consistent results than we're demonstrating using this model. So until we do, it's hard to rationalize doing a lot of intervention. And unfortunately, there's a big bias, including in functional medicine, where practitioners are making their living off of selling the treatments and the pills and the potions. And whether they realize it or not, sometimes there's a bias there that involves what those recommendations are making. There's also a problem of practicality. Because people don't want to quit smoking and drinking, they don't want to give up their meat, fish, fowl, eggs, and dairy products and sugar and processed foods. They're trying to do the next best thing. Dr. Longo, for example, tells people, look, you eat whatever diet you're going to eat, but just 5 days a month do Prolon. Why? Well, because he knows that it's very difficult to tell people, well, do Prolon, and then in between, let's adopt this health-promoting diet, regardless of what your individual beliefs might be. Our program trains doctors. We have, for example, Texas A&M has a functional medicine training program for physicians. They have their family medicine, functional medicine focus. And their students can rotate for a month as a part of their training at the True North Health Center. And one of the most common things that these doctors say when they come through is they say, wow, it's the first time I've ever seen patients with these conditions actually getting well. And we're essentially doing nothing. We're getting out of the way. We use fasting to normalize the system. We feed them a whole plant food diet. We get them to exercise appropriately, use their body properly, try to get them sleeping properly. There's no, magic pill, potion, powder stuff. And yet we're seeing consistent results in the conditions that we're selecting for. So the conditions that will respond best to this are conditions caused by dietary excess. So, that's why high blood pressure and diabetes respond so well. There are other conditions, neurologically mediated conditions. Conditions are primarily mechanical in nature. You wouldn't just do it. That's why we have chiropractors and naturopaths and acupuncturists and people to do different kind of intervention when that's necessary.
I think what you're doing is extremely admirable, commendable. The fact that you're doing the research to actually prove that the interventions you're doing are effective. I think that's great. We need a lot more research in that regard. But I would like to stand up for some of the other functional medicine practitioners who are not using your fasting approach. We all have our we all have our tendencies and the things that we have found to be useful. And a lot of us have found that when you take somebody who's on a typical standard American diet and they're suffering from all these different chronic diseases, which we know are all related to problems with the way they're eating and lack of exercise, et cetera, and exposure to toxins and exposure to mold and all these other things. And most of us have found that at least in, a big chunk of patients, 50% or more, we use some of these interventions and people feel better for the first time in years and decades. So, just like you are prejudiced towards fasting and have found great results, a lot of us have found great results using different sorts of nutritional interventions, including the prudent use of nutritional supplements.
Sure.
And so we're not necessarily only using nutritional supplements because that's how we make our money or because we're prejudiced towards those. We're using those because we found that they've been really efficacious for our patients.
Right. So the thing I would challenge doctors, though, to think about is that, I teach at a lot of the naturopathic colleges, and they talk about first-level therapeutic order intervention. You don't really get paid to do first-level therapeutic order intervention. You get paid to do procedures and to provide products. And so what happens a lot of times is there's a skipping over the time-consuming, difficult educational part of really teaching people how to live healthfully, or the advice that we're giving them.
Well, that's only if you're in the insurance model, right?
Yeah. whatever. You know, the naturopaths are
Well, I
not
mean, those,
insurance model because they're not covered by insurance. So they're in a cash-based model, and yet they're still skipping over that time-consuming, in my experience, and jumping into the pill, potion, powder stuff. And I think the power of naturopathic medicine is really in that first level therapeutic order intervention, which is what we try to do at True North Health, where we have the luxury of having patients living with us for anywhere from a week to a year. And you can really see what happens when you fully control that environment. It's very empowering. So I'm not sure that, you know, what the best strategy is on an outpatient basis. That's not, you know, I've had 35 years of inpatient work, but,
right.
you know, I do see that the results that I'm seeing and that we can demonstrate and document are very consistent. And I don't see a lot of stuff coming out of the outpatient practice that's documented to the level where it makes us want to try to implement those recommendations. And so, you know, you hear a lot of stories, but I'd like to see those documented. I'd like to see the outcome data. And
Well, I
I
mean,
think
there's
that's weak.
quite a number of I guarantee there's a lot more studies on the Mediterranean diet than there is on fasting. There's you know, quite a number of studies on the paleo diet or the ketogenic diet or different dietary interventions.
Oh, yeah, I've looked at those studies, and the good news is anything you compare to the standard American diet is likely to demonstrate some improvement. Something being less bad doesn't necessarily make it good. And so I think, again, in terms of critical evaluation about long-term sustainability, you'll see a lot of the stuff when people put people on high protein, high fat diets, they do well for a while because they get the fasting blunting effect of ketosis. So they're getting into ketosis, they're not as hungry, they lose some weight for a while. But then long-term, you see the devastating consequences of their gallbladder, their digestive system, increased risk of cardiovascular disease, atherogenesis. So I'm not so sure, depending on how you put that together.
The case. You know, if you monitor patients' lipids, they don't necessarily have devastating effects on lipids.
Well, I'm talking about more long-term effects, and particularly for the patients right now that we're seeing coming in that have, you know, made a good faith effort with high protein, high fat animal-based diets. We definitely see consistent and predictable results that happen long-term.
But since most since most cholesterol in the body is produced by the liver, then, you know, what's the problem with having a high animal fat diet?
Well, I think that the problem is a question of supersaturation, that, yeah, most of your cholesterol is made by your body. It's a necessary and essential nutrient. But when you supersaturate the system, then you begin to develop the problems that are pretty well demonstrated, that association between higher both refined carbohydrates and higher fat, high protein diets. I mean, we see it in patients when they're trying to regulate these conditions, particularly autoimmune conditions. And we can turn it on and off depending on what you're putting in their mouth.
I'm with you on the high refined carbohydrates and sugar, but I don't think we've really settled the question of whether a higher animal fat diet is associated with more heart disease or not. And the American Heart Association is still relying on some of the same studies from the 1960s to advocate for a low fat, higher carbohydrate diet, and consider the fact that the liver is producing cholesterol from glucose, not from saturated fat.
Well, we're not arguing with you on that point. I agree. Refined carbohydrates are one of the things that we eliminate. We also eliminate animal products and oil, salt, and sugar. So what we're down to is just whole plant foods: fruits, vegetables, grains, legumes, nuts, and seeds. And I think that, you know, although grains and legumes are not necessarily going to work well for all patients, some people do have sensitivity issues. The idea of eating those whole plant foods, you know, and, you know, you can debate whether you want to include animal foods in there or you don't want to include animal foods in there. But this idea of a whole plant food diet, I think, is finding at least some general consensus amongst most people. Certainly people that experiment with diet will find, I think, the simpler they get their diets and the more they get it back to whole foods, not highly processed, fractionated foods. I mean, I get into trouble at the national vegan conferences that I lecture at saying that, you know, as bad as animal foods might be with various issues, a lot of this highly processed vegan food may be actually even worse. And when you tell people they'd be better off eating meat than some of this processed, you get into a lot of trouble. So basically, I don't like any of it other than whole foods, you know. So I would argue on the idea that animal foods themselves, not dairy products so much, but meat and stuff, is a whole food. So if you're going to eat meat, just like you're going to eat anything, we recommend, obviously, you get animals that haven't been fed garbage and et cetera, et cetera. But I do think that they're like nuts and avocado and other rich foods, you can overdo it. And when you do overdo it, we see consequences physiologically. So now then the only question is what's overdoing it? And maybe there's some variation amongst individuals too about what their tolerances
And
and
I think there
capacities are.
clearly is.
Yeah, well, that may very well be the case. So we have a model with the conditions that we treat that we use universally, and that is a whole plant food SOS-free diet. And we know what those constitutes are, and we're able to monitor the outcome data. And the outcome data is consistent. It doesn't mean it's the only way to do it. It doesn't mean it's the best way to do it. But we do, we're at least making an effort to publish the demonstrable results. We lay out the protocol, and then people can decide for themselves whether that's going to be appropriate for them or for their patients.
Great. And the more data we get, the better.
Absolutely. But I think that we certainly don't have enough data arguing our case, but I think that people have this impression that there's this vast amount of clinical outcome data on these nutritional issues, and there really isn't. And some of the data that's there isn't as strong as it should be. So we're trying to do our part of, improving that. And particularly looking at long-term outcome data.
To get good nutritional data, especially when so many of the studies are using these food frequency questionnaires, which are, like a joke. I just saw something about, I think the headline was, red meat causes something bad, and they followed people for 5 years, and the the way they monitored this was they gave them a 4-day food frequency questionnaire at the beginning of the study. And after 5 years, that's supposed to account for the way they were eating. I mean,
yeah, of course,
that's
not good science. And the conclusions that are driven are oftentimes weak as well. We are in the process right now of validating a food questionnaire for this type of a diet. We're doing this with our colleagues from Cornell. And it's very difficult. It's challenging to come up with reliable and then validating the data. It takes a lot of effort and work. And you can't do studies that, like you said, where you have a single intervention and then try to do long-term conclusions. You have to be able to do ongoing monitoring. We're fortunate, though, we're in a position where we have a long-term relationship with these patients that are involved in these studies. Because we have to, for example, in our lymphoma patients, 10% of patients go through spontaneous remission with lymphoma, but they typically don't sustain it. And so unless you have good long-term outcome data, nobody's really that impressed. So we are in the position to be able to do long-term tracking and monitoring of these patients. So we'll find out, if we're right and everybody else is wrong, or if we need to improve or modify our stand. But I would say that, if the data is strong, we're happy to, evaluate, modify, and we're happy to study, whatever it is that makes some kind of logical sense. We believe that what we do makes sense. We've written a book called The Pleasure Trap. We've laid it out. We've referenced it, and we're open to whatever suggestions or criticisms people want to give us.
Awesome. So how can our listeners find out about your True North Health Center, and what do they need to do if they want to come there?
We have a nice service for your listeners. If they're interested in knowing whether we think fasting and this approach might have some use to them, they can go to our website at healthpromoting.com. Complete
what is
healthpromoting.com.
Healthpromoting.com. Okay.
If they go in and they fill out the registration forms, it gets me their medical history. We offer a no-cost phone conversation where I'm happy to review their history with them and talk to them about whether or not there's anything we do that might be relevant. Or if they don't live near us, we have a number of doctors that we've trained around the country that we can refer them to their facilities that do medically supervised fasting if that seems to be appropriate. And all of our studies, all of our papers are freely available on our website. There's also something called True North TV on there. It has all the video links. There's a lot of information that people can get. We have 3 cookbooks out that are vegan SOS-free cookbooks, so you can show people how to make food simple. Even simple enough I can make it. So that's kind of cool.
Awesome. Thank you, Dr. Goldhamer.
Oh, it's my pleasure. It's nice talking to you.